Welcome to the deep dive. Today, we're really diving into one of the most critical challenges we face as interventional radiologists, handling bleeding gastric varices and, well, also refractory hepatic encephalopathy.
Yeah, these are tough situations. You're dealing with patients who are often incredibly sick.
Right, and when those gastric varices actually start bleeding, it's a true emergency. The morbidity and mortality are just alarmingly high.
Absolutely. The stakes are incredibly high. We're talking scenarios where um, every little anatomical detail, every procedural step, every potential complication, it all demands just expert level foresight and really meticulous management.
There's really no room for error, is there?
Very, very little. Precision is key.
So that's our mission today. We're going to unpack retrograde transvenous obliteration, RTO techniques. Specifically, we'll hit BRTO, PARTO, and CARTO.
Yeah, we'll break down the anatomy. You absolutely have to know the really detailed pre-procedural workup that sets you up for success.
The technical steps for each one, and maybe most importantly, how you recognize, prevent, and manage the complications that can come up with these life-saving procedures.
Exactly. Think of this as, well, maybe a shortcut to getting a handle on the nuances of RTO. We want to arm you with insights that sharpen your planning, help you see challenges coming, and, ultimately optimize outcomes for these really complex patients.
Directly addressing what we deal with day to day. Okay, let's build this from the ground up. Section 1, the foundation. Understanding gastric varix anatomy and bleeding risk.
Right, foundational knowledge.
And we're starting, maybe surprisingly for some IRs, with Saren's classification. It feels kind of endoscopic, right? But why is it so fundamental for us?
It really is fundamental because it gives us that crucial initial clinical context we needed to make sense of our imaging and plan the intervention. Endoscopists use it based on location and relationship to esophageal varices.
Oh.
So when you understand Saren's, you can directly link your CT or MR findings to what the GI team saw. It immediately points you towards the high-risk varices, the ones that are usually our main targets for RTO.
Ah, so it's not just their classifications, like our roadmap tells us where to focus on the scans.
Precisely. It flags the varices most likely to cause a major bleed. It's a direct guide for your imaging attention.
Okay, so give us the breakdown. What are the Saren tips we really need to know, and what's the implication for each from an IR perspective?
Sure. There are four main types. Knowing them is, well, critical for risk assessment and figuring out your target.
Got it.
First, you've got gastroesophageal varices, type 1, or GOV1. These are basically esophageal varices continuing down onto the lesser curve of the stomach.
Okay, lesser curve.
They're the most common, maybe 75% of cases. Now, from an IR standpoint, while they're common, they're less often our primary RTO target unless they're really bleeding badly and endoscopy failed. Their drainage might be more towards the esophagus.
Makes sense. What's next?
Next up are GOV2s, also esophageal varices extending down, but these go into the fundus.
Fundus. Okay, big difference.
Huge diff for us because GOV2s carry the second highest bleeding risk right after IGV1s. Their spot in the fundus often makes them good candidates for RTO, especially if there's a nice gastrorenal shunt nearby. The bleeding risk is significant.
Okay, GOV1, lesser curve, GOV2, fundus, higher risk. Then the isolated gastric varices. These sound particularly important for RTO.
They absolutely are. Isolated gastric varices type 1, or IGV1, are found only in the fundus. No related esophageal varices.
That's fundus.
Right. And these are incredibly important for us because they have the highest bleeding risk of all types, period.
Highest risk.
Which makes them prime candidates for RTO, often showing up as, those massive life-threatening bleeds. If you see an IGV1, your first thought should be, find that gastrorenal shunt for RTO.
Okay, IGV1, fundus only, highest risk, think RTO immediately. And the last type?
That's IGV2s. These are isolated varices too, but they're elsewhere in the stomach body, antrum, pylorus. Least common type.
So not fundus.
Correct. They can bleed, sure, but their location and drainage patterns often make them, well, less suitable for RTO compared to IGV1s or GOV2s. You might think about other options first.
So boiling it down for RTO suitability, we're mainly focused on IGV1 and GOV2.
Exactly. Primarily because of that high bleeding risk and the fact they often drain via shunts that are accessible for RTO. When a patient comes in with one of those, it really dials up our assessment for doing an RTO procedure.
That clarifies things perfectly. It's a clinical roadmap guiding our technical approach. Okay, let's move from the surface view to the plumbing underneath the afferent or inflow veins. Why is identifying these so critical? You mentioned predicting sclerosant behavior.
Yes, absolutely critical. This gets right into the fluid dynamics of the procedure itself. Success and safety hinge on this. The main inflow veins feeding these varices, usually the left gastric vein, LGV, and the posterior gastric vein, PGV.
LGV and PGV, the main players.
Mostly. You might see short gastric veins, sometimes gastroeploic veins contributing, but often only if the main ones are already blocked or something.
Hmm.
Identifying these, and crucially, how they're configured, it directly tells you how your sclerosant is likely to flow once you inject it.
And getting that wrong could mean...
Could mean non-target embolization, putting sclerosant where you don't want it, or just not fully obliterating the varix, leaving the patient at risk. It's a big deal.
So what's the practical difference then if you've got one inflow vein versus multiple? Sounds like a major tactical consideration.
It's a huge difference. And honestly, it's a common pitfall. If you've got just a single afferent vein, what you see called type I things are generally more straightforward.
Okay, type I, single vein, easier.
Yeah. You block the outflow, the efferent veins, and the high portal pressure pushes the sclerosant nicely throughout the varix. Good obliteration. But when you have multiple afferent veins, like in Kiosu type 2 or 3, things get tricky. Here's the critical point. One of those afferent veins can, sort of paradoxically, turn into a draining pathway once you block the main efferent shunts.
Wait, an inflow vein starts acting like an outflow? How does that work?
Think pressure dynamics. You block the main drain, the shunt, pressure builds up. If there's another potential inflow path connected, that pressure might force flow out through that secondary afferent back towards the portal system.
Ah, okay, so you're injecting sclerosant, expecting it to fill the varix, but some of it might just escape back out through this unexpected drain.
Precisely. That paradoxical flow. It leads straight to unintended sclerosant efflux into the portal system. Big risk of non-target embolization, damage to the portal vein, or just incomplete treatment because the sclerosant didn't stay put long enough.
So recognizing that possibility on the pre-op scans changes your whole game plan.
Absolutely.
Yeah.
It means you might need to plan to embolize that other afferent vein too, or at least inject very cautiously. Watch the flow extremely carefully under fluoro. It demands foresight and potentially adjusting your technique on the fly. Crucial for safety.
Wow, that's a critical detail, avoiding complications right there. Okay, inflow understood. Now, the outflow, the efferent pathways, the gastrorenal and gastrocaval shunts. You said RTO isn't even possible without these.
Exactly. This is the fundamental requirement. Non-negotiable. The presence of a suitable, accessible, infradiaphragmatic portosystemic shunt is the absolute prerequisite for any RTO procedure.
Why infradiaphragmatic specifically?
Because that's typically where these large dominant shunts connecting the gastric varices to the systemic circulation, like the renal vein or IVC, are located, and where we can access them retrogradely from the venous system, usually the femoral or jugular vein.
Gotcha. So the whole technique relies on accessing and blocking these shunts.
Correct. We go in retrogradely, find the shunt, and occlude it either temporarily with a balloon in BRTO or permanently with a plug or coils in CARTO. This blockage then allows the sclerosant to fill the varices backward. If there's no good shunt, or it's too small, too twisty to get into, RTO is off the table.
So the pre-procedural imaging absolutely has to map these out?
Has to. We need to know the exact anatomy, the course, the diameter for sizing our devices, how easy or hard it will be to get into. It dictates the whole approach, the access site, the tools, and ultimately whether the procedure is even feasible. Miss this, and you're setting up for failure or worse.
And what are the usual suspects, the most common shunts we're looking for?
The big one, in about 80–85% of cases, is the gastrorenal shunt, GRS. Usually it's gastric varices draining into the left renal vein, often via the inferior phrenic vein joining it. That's our main target.
GRS, the workhorse.
Definitely. The second most common is a direct gastrocaval shunt. Here, the varices drain straight into the IVC, again, maybe via the inferior phrenic or sometimes a pericardiophrenik vein. Less common than GRS, but still a good RTO target if it's accessible.
Are there other less common routes?
Yeah, sometimes you see more complex drainage through things like ascending lumbar veins, the perivertebral plexus, intercostal veins, occasionally even the azygos system. But GRS and direct gastrocaval are the ones we encounter most often and are generally the most suitable for RTO access. We need that pre-op CT or MR to show us exactly which one we're dealing with, its size, flow, and any tricky turns.
Okay, individual veins mapped. Now let's tie it together with those classifications that directly guide our strategy. Back to Kiosu et al.'s classification for efferent veins. Can you detail the types again and hammer home the practical implications for us. How does it help avoid reflux?
Right, this after classification is paramount because it tells you the inflow pattern, which directly informs strategy and crucially helps predict that risk of sclerosant going where you don't want it.
Okay, type I.
Type 1, single afferent vein, usually LGV or PGV, generally the most straightforward. You block the outflow, inject, and the high portal pressure should fill the varix nicely. Ideal scenario.
Simpler case. But type 2 and 3, that's where the potential problems really lie.
Exactly where you need to be extra vigilant. Type 2, two distinct afferent veins, often LGV and PGV feeding the same varix complex. The big risk here, that paradoxical flow we discussed. Once you block the main shunt, one of these afferents can act like an outflow drain.
Leading to sclerosant escape?
Yep, efflux back into the portal system. Incomplete treatment, non-target embolization risk. Recognizing this potential on the scans means you might need to be ready to embolize one of those afferents or just inject super carefully and confirm complete stasis.
And type 3 adds another twist.
It does. Type 3 is more complex. You have your main afferents feeding the varix, plus another gastric vein that drains directly into the shunt itself, bypassing the varix.
Whoa, okay. So a direct shortcut from the stomach to the shunt, missing the varix.
Exactly. If you don't spot and deal with that accessory draining vein, your sclerosant has a direct path to just wash out into the systemic circulation via the shunt, completely missing the target varices.
So the accessory vein almost always needs to be embolized first.
Almost always, yes.
Yeah.
You have to block that pathway before injecting sclerosant into the main varix complex to ensure it stays put and does its job safely. Failing to recognize a type 3 is a major setup for procedural failure and potential complications. This classification system isn't just academic. It translates anatomy directly into practical, tactical decisions for us on the table. Helps anticipate challenges, plan for extra steps, like embolization. It's a critical planning tool.
Incredibly useful framework, like a pre-op checklist based on inflow anatomy. Now, Kyosu has also classified the efferent veins, the outflow. How does this classification influence complexity, and what's the main danger if we don't fully assess all those outflow collaterals?
This efferent classification is just as vital. It tells you how complex the shunt occlusion will be, and importantly, the risk of leaving escape roads open, leading to residual flow or later recanalization.
Okay, so type A.
Type A is the simplest. One single draining shunt, like a GRS or direct gastrocaval. That's your ideal, straightforward occlusion target.
Makes sense. Type B.
Type B has that single main shunt, but also one or more collateral veins draining towards the systemic circulation without forming another big, discrete shunt connected to the varix. Think pericardiophrenik veins, ascending lumbars, intercostals, paravertebrals, maybe draining towards the azygos. These can be subtle sometimes.
And there are subtypes here too. B1, B2, B3.
Yes, just to grade their size and significance. B1 are small collaterals, B2 medium, and B3 involves large, high-flow collaterals, but still without a distinct, easily targetable second major shunt.
Okay. Then type C. Sounds complex.
Type C is where the varices connect to both a gastrorenal and a gastrocaval shunt, two major outflow pathways, high-flow situation. Subtype C1 has a small second shunt that might be tough to catheterize, while C2 has two sizable catheterizable shunts.
Double trouble. And type D.
Type D is often the toughest for RTO. There's no distinct large shunt. Drainage is mainly via lots of small collaterals that don't directly guide to the IVC or renal vein in a way we can easily access.
So the big pitfall here, if you just block the main shunt in a type B or C or ignore smaller pathways, you could fail.
Precisely. That's the danger. You leave escape routes open, blood finds another way out. This means incomplete obliteration of the varices right now, or shunt recanalization down the road. The patient is still at risk for rebleeding. All that effort potentially wasted.
So this classification demands a really thorough search for all efferent pathways on the pre-op imaging.
Absolutely. You need to plan for potentially embolizing significant collaterals too, not just the main shunt. It's about achieving truly comprehensive variceal thrombosis by addressing every major outflow path. This might even need provocative angiography during the diagnostic phase to really map everything out.
Amazing level of detail required. So Kyosu gives us the structural map, but then Hirota et al. Added a functional layer with their grading based on balloon occluded retrograde venography, the BORV. How does this complement the anatomy, and how do we use it during the procedure?
Hirota's grading is fantastic because it gives you a dynamic, real-time snapshot of the shunt hemodynamics. It's invaluable for predicting how difficult the sclerosant injection and retention will be. It's based on what you see when you inflate the balloon in the shunt and inject contrast retrogradely.
Okay, walk us through the grades.
Grade 1. Varices fill up nicely with contrast. No significant collateral seen. Great sign-contained system. Grade 2. You see a few small collaterals, but the contrast stays in the varices for more than 3 minutes. Still pretty good, just acknowledging minor outflow elsewhere. Grade 3. Now you see medium or large collaterals. The varix only partially fills, and the contrast washes out in less than 3 minutes. This tells you there's significant washout happening, but it'd be harder to keep sclerosant in place.
Okay, so grades 1 and 2 are relatively good. Grades 3 starts showing challenges. What about 4 and 5?
Grade 4. Lots of large collaterals seen, and critically, the varices don't even fill well with contrast during the BORV. This screams that the shunt and collateral flow are so dominant, getting sclerosant effectively into the varix itself will be extremely tough. And grade 5 is the ultimate challenge. The shunt is just too big or the flow too fast for your balloon to even occlude it properly. The balloon might not seal or flow just rushes around it. Effective sclerosant delivery is likely impossible with standard BRTO.
So this Retrograde gives you immediate functional feedback that anatomy alone doesn't.
Exactly. It complements Kiosu beautifully. You might have anatomically simple efferents, Kiosui A, but functionally, the flow is so high, it's a Hirota 4 or 5. That tells you immediately you'll struggle with sclerosant retention. It predicts technical difficulty right there on the table.
And signals you might need more sclerosant or maybe switch techniques.
Precisely. A high Hirota grade might push you towards needing higher sclerosant volumes, maybe considering PARTO or CARTO, for a more definitive mechanical block that isn't relying on just the balloon holding back massive flow. It's a functional red flag that directly impacts your intraprocedural decisions before you commit to injecting the sclerosant.
Okay, amazing foundation laid with anatomy and function. Now let's quickly connect this back to the clinic. The risk factors for bleeding. Why is all this crucial? What are the clinical signs that tell us as IRs this patient needs intervention?
Right, these are the triggers bringing patients to our attention, the reasons we need this detailed understanding. Key risk factors are, first, large varix size, usually over 1 centimeter, suggests higher wall tension. Second, red spots seen on endoscopy. Those cherry red spots are red whale signs. They indicate really thin, fragile varix walls about to pop.
Location matters too, right?
Absolutely, especially those high-risk locations we pinpointed. IGV1 and GOV2 in the fundus. They just seem more prone to high-pressure bleeds. And finally, severe liver dysfunction, a high Child-Pugh or MELD score. Poor liver function means impaired clotting and unstable hemodynamics, seriously increasing bleeding risk.
So put together, large fundal varix, maybe red spots, patient has bad cirrhosis.
That patient is a ticking time bomb. That clinical picture is a direct signal for us. Get detailed imaging now to assess for RTO suitability. The bleeding risk is sky high, and this intervention could absolutely save their life.
Okay, perfect transition. That brings us to the blueprint, meticulous pre-procedural evaluation for RTO techniques. We have the map. Now, how do we use it? Let's talk about the detailed pre-procedural plan, starting with general clinical considerations, specifically the indications. It's not just about stopping an active bleed, is it?
No, definitely not just active bleeding anymore. While yes, bleeding GVs refractory to endoscopy is a primary, often urgent indication, RTO's role has really expanded. We also use it for preventing rebleeding in high-risk patients after they've been stabilized initially.
Proactive prevention makes sense.
And, critically, treating refractory hepatic encephalopathy, HE, when it's clearly caused by a large portosystemic shunt. RTO closes that shunt, diverting ammonia away from the brain, and can dramatically improve or even resolve the HE.
That's huge for quality of life.
Massive. It's also an option for patients who can't tolerate a TIPS, maybe due to heart failure, or if TIPS has failed them. We also think about it for prophylactic treatment of really large, scary-looking GVs that haven't bled yet but seem poised to.
Treating before the disaster strikes.
Right. And occasionally, particularly with BRTO, it might even help manage portal hypertensive gastropathy if that's causing chronic blood loss.
So it's really become part of a more proactive, holistic management plan for portal hypertension complications, not just a rescue maneuver.
Exactly. RTO is integrated into long-term strategy now. We're looking at preventing future problems, keeping people out of the hospital, improving their overall well-being, not just putting out the immediate fire.
Just as vital as knowing who needs RTO is knowing who can't get it. Let's cover contraindications. There's one absolute one that's crucial.
Yes. Complete main portal vein MPV thrombosis is an absolute contraindication. Cannot stress this enough.
Why is that so definitive?
Because in that situation, the GRS or other shunt we'd target might be the only significant outflow for the entire splanchnic circulation, the gut and spleen, if you block that last exit.
Pressure skyrockets in the mesenteric veins.
Exactly. You cause acute, severe mesenteric venous hypertension, massive bowel edema, potentially leading to catastrophic mesenteric ischemia, bowel infarction. It can be rapidly fatal. It's an absolute no-go.
Crystal clear. Okay, but then there are the relative contraindications needing more judgment. Walk us through those and the reasoning.
Right. These need careful weighing of risks and benefits, often a team discussion. First, severe uncorrected coagulopathy. While we can give products, uncontrolled bleeding during a complex vascular procedure is a major risk.
Makes sense. What about ascites?
Refractory or large volume intractable ascites is a big concern. RTO will increase portal pressure, at least temporarily, as flow redirects. In someone already overloaded with fluid, this can make ascites significantly worse, harder to manage.
And liver function itself.
Severe liver dysfunction, think high child PU B or C. Their liver is already struggling. The sudden hemodynamic shift from closing a large shunt might push them into further decompensation. The risk is much higher.
You also mention high-risk esophageal varices, EVs. Why are those a relative contraindication? Seems like we're treating varices anyway.
It's about preventing a new problem. High-risk EVs absolutely need endoscopic treatment before RTO. Because RTO increases portal pressure, it can cause new EVs to form, or worse, make existing ones much bigger and more likely to rupture. So you treat the EVs first to avoid trading one bleeding source for another.
Proactive management again. Okay. And the difference between complete and partial portal vein thrombosis. You said partial is only relative.
Yes, this is a key nuance. While complete MPV occlusion is absolute, partial MPV thrombosis or compensated thrombosis with cavernous transformation is relative. In some cases, paradoxically, closing a competing shunt like the GRS might actually improve flow through the remaining patent portal vein or the cavernoma by redirecting blood towards the liver.
Oh, interesting. But that requires careful assessment.
Extremely careful. You need sophisticated pre-op assessment of liver function and detailed flow analysis on imaging to be sure the liver can handle that redistributed flow. It's not just about seeing some patent vessel, it's about understanding the functional hemodynamics. Often needs advanced imaging interpretation.
What other relative contraindications are on the list?
We look closely at poor renal function or known allergies, obviously, because of contract and potential sclerosant toxicity. The obvious one, absence of an accessible shunt, makes it technically impossible. Hepatofugal portal flow, where blood is already flowing away from the liver in the portal vein, closing a major shunt, could worsen liver perfusion.
Okay.
Also, just a lack of suitable venous access or anatomy, where you just can't get a good seal with your balloon or plug. And some consider large hepatocellular carcinoma, like 5 centimeters, a relative contraindication due to concerns about altering tumor perfusion. It's a complex interplay, always needing individual risk assessment and that multidisciplinary team discussion with hepatology and GI.
Which leads perfectly into the essential clinical assessments. It's so clear this is about managing the whole patient, not just the plumbing.
Precisely. That multidisciplinary team approach is non-negotiable. We need input from hepatologists, endoscopists. RTO isn't isolated. It hits liver function, renal function, fluid balance systemically. So that holistic pre-op evil is key to picking the right patients, managing their issues, and anticipating problems. The prep work is often just as critical as the procedure itself.
So run us through that essential checklist. What absolutely has to be evaluated for every RTO candidate?
Okay, top of the list, liver function, full stop. Bilirubin, INR, albumin, the whole panel, plus calculating the MEL-AND score gives you that baseline of liver reserve.
Got it. Liver function first.
Second, blood counts and renal function, CBC, especially hemoglobin if they're bleeding, and creatinine, BUN are vital, particularly if you're considering ethanolamine oleate, EO, which has that risk of hemolysis causing renal injury. You need that baseline GFR.
Renal function, check.
Third, fluid status. Got to assess ascites, pleural effusions, edema, check for hypotension. Fluid overload makes everything harder post-op when portal pressure rises. And you need to be careful not to over-resuscitate with fluids, which can worsen portal hypertension.
Fluid balance, critical.
Fourth, mandatory upper endoscopy. Confirms the GVs, checks for active bleeding, and crucially rules out those high-risk EVs that need treatment first. Ideally done at the same center as the RTO for good communication.
Makes sense. What about tips? Does that factor into the pre-RTO thinking?
Yes, definitely. For patients who have both GVs and refractory ascites, hydrothorax, or high-risk EVs, you might consider doing TIPS either before or even concurrently with RTO. TIPS decompresses the portal system, addressing the fluid or EVs, while RTO targets the GVs. It's part of that multidisciplinary strategy discussion.
Okay. What else is on the clinical checklist?
Careful management of volume, plasma, and procoagulants. stabilize the patient, maybe target a specific hematocrit, ensure platelets and clotting factors are adequate for the procedure.
Hemostasis prep.
Yep. And thorough documentation of their bleeding history, HE history. Finally, meticulous planning for sedation and preparation. Usually conscious sedation or general anesthesia. Prophylactic antibiotics are standard. Continuous hemodynamic monitoring. And precise planning of your vascular access route, maybe even planning a backup route.
A really comprehensive blueprint. Okay, now imaging. You mentioned a paradigm shift away from basic ultrasound. What does that mean for us in practice?
It means that for detailed RTO planning, advanced cross-sectional imaging CTA or MRA is now the standard of care.
Yeah.
Ultrasound gives you initial flow info, sure, but the sheer complexity of GV and shunt anatomy, those subtle Chiyosi variations, the exact shunt diameter needed for sizing plugs or balloons, it absolutely demands the high-resolution and multiplanar views you get from CT or MR.
So it's gone from just diagnosing to really detailed surgical level planning.
Exactly. We need near-perfect anatomical knowledge before we go in. That precision planning directly correlates with success and, just as importantly, minimizing complications. It's a fundamental shift in how we approach these cases with imaging.
Okay, CTA and MRA are the workhorses. Specifics for each. And any key technical tips for getting the best images.
CTA is excellent. Great for seeing the main portal vein patency, thrombus, cavernous transformation, ruling out that absolute contraindication. Superb for delineating the GRS, its origin, course, drainage. Varices show up as enhancing structures. Key technical tip, no oral contrast. Tell the text, make sure it's not given. It just obscures the varices you need to see clearly.
Good tip. No oral contrast for RTO planning CTA and MRA-CA.
MRA or contrast-enhanced MRI is a great alternative, especially for contrast allergies. Gives similar excellent visualization of portal veins, shunts, GVs, afferents. Dynamic post-contrast sequences are really valuable, showing flow dynamics in different phases. Even T2 can show varix components sometimes. And remember, triphasic CT or MRI is specifically highlighted as ideal for PARTO planning.
And Doppler ultrasound. Still useful for a quick look.
Yeah, Doppler US is fine for an initial check of MPV patency, flow direction, splenic vein. Good screening tool. But its utility for the detailed, comprehensive anatomical mapping needed for RTO planning. It's really limited compared to CT or MR. You just don't get the spatial resolution or the full 3D understanding you need for precise planning and device sizing. Screening? Yes. Planning? No.
Okay, so pulling all that advanced imaging insight together, what's the definitive pre-procedure checklist for us? The key imaging objectives before taking an RTO patient to the lab. Our mental roadmap.
This is the roadmap. Nail these points on imaging review, and you're setting yourself up for success.
Define the shunt and varix anatomy precisely. Map all efferent and efferent veins. Figure out the Chiyosu types. This tells you your targets and any extra veins you might need to embolize.
Anatomy first. Check.
Second, accurately measure the GRS diameter or other target shunt. Absolutely critical for sizing your balloon or plug. Measure it carefully, maybe at a couple of points. Undersize, poor seal, oversize too much, risk injury.
Diameter for device sizing. Check.
Third, plan your shunt cannulation approach. Based on the anatomy tortuosity, origin imaging guides your access route, femoral, IJ, and what wires and catheters you'll need.
Access plan. Check.
Fourth, identify any portal or splenic vein thrombosis. We know complete MPV is out, but assess any partial thrombus carefully to understand the hemodynamics.
Thrombosis assessment. Check.
Fifth, assess a site's extent. Helps anticipate fluid shifts and manage expectations.
Sites check.
Sixth, confirm MPV patency. Double check that occluding the shunt won't cause mesenteric ischemia. Look at flow direction too.
MPV patency confirmed. Check.
Seventh, document the targetable GRS-GCS. Make sure RTO is actually feasible. And finally, assess GV presence extent. Confirm your target pathology. Each point directly translates to a procedural decision, maximizing success and minimizing risk.
That's a perfect pre-flight check. Now, you mentioned PARTO specifically benefits from triphasic imaging. Let's dig into PARTO's specific pre-op considerations. How does it refine imaging needs, and what else is unique to its prep?
Right, PARTO uses that permanent plug, adding another layer of precision. While it shares the general prep, it particularly emphasizes triphasic contrast-enhanced CT or MRI. Why triphasic? Because it gives you that dynamic flow information across arterial, portal venous, and delayed phases.
So better understanding of flow dynamics for plug placement.
Exactly. You get incredibly detailed insights into blood flow direction, shunt dynamics, how the varices fill relative to feeders and drainers. This is super critical for PARTO, where precise plug sizing and placement are everything. It helps predict exactly how sclerosant will distribute after the plug is in, and helps you visualize all potential outflow pathways to ensure complete occlusion and avoid non-target embolization. It's about knowing precisely where that plug needs to land for a perfect seal.
Makes sense for a permanent implant. Beyond imaging, any specific lab or clinical prep emphasized for PARTO?
The lab workup remains comprehensive. CBC, full coags, INR, PT, APTT, liver and renal function tests, Melody score calculation, all crucial for risk assessment. Sedation is typically conscious sedation managed by anesthesia or general anesthesia. Prophylactic antibiotics are standard. Bowel prep usually isn't needed, which is nice. And again, meticulous clinical documentation. Bleeding HE history, endoscopic proof of GVs, and that cross-sectional imaging clearly showing an accessible shunt. Every piece informs the plan.
Truly thorough blueprint. Okay, let's shift to the tools themselves, the sclerosants and embolic agents. The sources mentioned an evolution and diverse choice. What's behind that trend? Balancing efficacy and safety.
Absolutely. That evolution is all about the ongoing effort to find the sweet spot, effectively obliterating these dangerous varices while minimizing harm to the patient. There's a clear push towards reducing iatrogenic complications.
No so.
Through more careful agent selection, refining how we deliver them, and definitely the increasing use of mechanical devices like plugs and coils alongside or instead of just sclerosants, it's about getting controlled delivery, keeping the agent where it needs to be, reducing systemic exposure and those nasty side effects. Each agent has its pros and cons.
Okay, let's break down the main players, starting with sodium tetradecyl sulfate, STS, common in the U.S.
Very common here, yes. STS is relatively inexpensive. It's a chemical irritant, causes rapid permanent damage to the endothelium inside the varix and shunt, leading to thrombosis and scarring. We often use it as a foam.
Why foam?
The foam prep typically mixing lipiodol, 3% STS, and gas, air or CO2 in a specific 1.2.3 ratio increases the surface contact area inside the varix and makes it less easily diluted by blood, so it's generally more effective.
Success rates and risks.
High technical success, reported 79-100%, generally seen as having fewer complications than older agents like EO, but rare serious side effects can happen. Pulmonary edema if it gets into the lungs, portal vein thrombosis if there's significant reflux, needs careful technique, good balloon occlusion.
What about polidocanol?
Polidocanol offers pretty comparable efficacy to EO, but generally with a lower complication rate. A really nice feature is its local anesthetic property. Patients often report significantly less pain during and after compared to other agents. That's a big plus for patient comfort.
Okay. Now, ethanolamine olathe, EO, sounds like this one has more baggage, especially systemically.
It definitely does. EO was historically preferred, especially in Asia, and it's still used, but it comes with significant, well-known systemic side effects that have led many places to move away from it.
Like what specifically?
The big one is dose-dependent hemolysis breaking down red blood cells. This releases free hemoglobin, which is toxic to the kidneys, leading to renal tubular injury and potentially acute renal failure. Serious stuff.
Wow, kidney failure risk. Anything else?
Yes. Also pulmonary edema, cardiogenic shock, even DIC, disseminated intravascular coagulation, really significant potential toxicities. There's been some exploration of using haptoglobin to bind the free hemoglobin, but it's not FDA approved for that here. When used, it's typically a 5-10% EO mixed 1.1 with contrast. If you use EO, you have to watch closely for signs of hemolysis like dark urine and monitor renal function very carefully.
Good to know the risks. Are there other common agents we use in RTO? Glue? Gelfam?
Yeah. NB2 cyanoacrylate glue is effective, especially for small collaterals, but it's more expensive. It polymerizes instantly on contact with blood, forms a hard cast. The big risk is migration if not injected perfectly, so you need meticulous technique, often with a microcatheter placed very distally. Gelfam is common, inexpensive, often uses particles. There's also a technique called BRTO gelatin ethanolamine RTO using a mix of gelatin sponge, EO, and contrast. Some studies suggest it might allow for less sclerosant volume and shorter procedure times.
And finally, the mechanical stuff for PARTO and CARTO. Plugs and coils.
Right. For PARTO, it's the Amplatzer vascular plug, AVP, like the AVP 2 or SIVE. Self-expanding mesh plugs for permanent occlusion. The absolute key technical point here for us. Oversize the plug by 20-30% relative to the shunt diameter.
Why so specific on the oversizing?
Crucial for secure fixation. Prevents migration. If you undersize, that plug can dislodge and travel potentially to the lungs or heart. Huge complication. So 20–30% oversizing is standard practice for prevention. For CARTO, we use coils, usually platinum embolization coils deployed into the shunt. They create a mechanical blockage and also act as a scaffold for thrombosis, enhancing the effect of any co-injected sclerosant by slowing flow. Again, precise technique is vital to pack them densely and avoid coil migration.
So the choice of agent or device isn't random at all. It's a very calculated decision based on the patient, the anatomy, the technique.
Absolutely. Understanding the pros, cons, risks, and side effects of each is critical for tailoring the approach and ensuring patient safety.
Okay, foundation, blueprint, tools. Now let's get into the procedures themselves. BRTO, PARTO, CARTO. Detailing the nuances. You said the evolution from BRTO reflected refinements. What drove that?
Exactly. BRTO was the pioneer, but its reliance on that prolonged balloon inflation had inherent challenges and risks. PARTO and CARTO evolved specifically to address those issues, aiming for more stable, often faster shunt occlusion, potentially reducing complications associated with the long balloon dwell time.
Let's start with the original BRTO, balloon-occluded retrograde transvenous obliteration.
Yeah.
Walk us through the mechanism and key technical points.
Okay, BRTO, access usually via femoral veins, sometimes IJ. You navigate a balloon catheter into the gastrorenal shunt, inflate the balloon, completely blocking outflow from the shunt.
Balloon up, shunt blocked, then.
Then, through the same catheter, you inject your sclerosant STS foam as common retrogradely. It flows backwards into the varices, filling them up against portal pressure. The sclerosant damages the lining, causes thrombosis.
And the key challenge or consideration here is
The prolonged catheter dwell time. This is the main thing distinguishing it from PARTO-CARTO. The balloon needs to stay inflated, sometimes for 15, 30, even 45 minutes or more, to let the sclerosant work and form a stable clot throughout the whole varix complex.
that long dwell time sounds like it could cause issues.
It can. Risk of venous thrombosis around the catheter, patient discomfort needing deeper sedation. You need continuous fluoro monitoring to make sure that balloon stays put and doesn't deflate or migrate during that whole time.
Okay, so PART was designed partly to avoid that long balloon time.
Yeah.
Tell us about PARTO, plug-assisted RTO. How does it work technically, and what are the critical prevention steps for us?
PARTO swaps the temporary balloon for a permanent mechanical block. You deploy a vascular plug, like an amplexer, to occlude the shunt permanently. Access is similar. Now, the critical technical points for prevention. First, as we said, oversize that plug by 20–30% compared to the shunt diameter. Absolutely vital for secure fixation, preventing migration. Deploy it carefully, not too close to the renal vein or IVC junction.
Oversize the plug. Got it. What else?
Second, be aware of delayed plug expansion. It might look seated initially, but check again after 5–10 minutes with another venogram. Make sure it has fully expanded and there's no residual flow around it. If there is, you might need another plug or some coils.
Check for complete seal after a few minutes. Good point.
Third, consider a dual microcatheter technique. One microcatheter deploys the plug, another parallel one, positioned just distal to where the plug will land, is used for the sclerosant injection into the varix. This lets you place the plug and embolize almost simultaneously, offering great control. These steps are all about precision, ensuring complete obliteration, and specifically avoiding that dreaded complication of plug migration.
Makes sense. More control, permanent block. Now, CARTO, coil-assisted RTO, how does this fit in? Uses coils instead of a plug.
Exactly. CARTO uses embolization coils, typically platinum, deployed into the shunt to create the occlusion. Sclerosant is often injected alongside or after the coils are placed. Access is similar.
What's the advantage of coils here?
The coils provide both a mechanical block and a scaffold. They slow down flow significantly within the shunt and varix and provide a large surface area anitis for thrombosis, which can enhance the sclerosant's action and stability.
And the key technical demand for CARTO, avoiding coil migration.
Precisely. Precise coil deployment technique is crucial to avoid migration. Coils can potentially travel, especially in high-flow shunts. You need careful coil sizing, often slightly oversized 10–20%. Controlled deployment, building a dense, stable pack that completely blocks the shunt. Long-term stability against recanalization is also something to consider with coils. And just to be clear, this CARTO is totally different from the CARTO mapping system in EP labs.
That's good clarification.
Okay.
Techniques detailed. Now, advantages, disadvantages, and crucially, the complication profiles. This evolution seems driven by mitigating specific risks.
Totally. Understanding why you might choose PARTO over BRTO, or vice versa, comes down to these trade-offs, enhancing safety, efficiency, and completeness of obliteration by addressing known weaknesses.
Let's focus first on BRTO-specific complications. What are they? How do we spot them, prevent them, manage them?
Okay, BRTO specifics often relate to the balloon and sclerosant. One risk is pulmonary embolism of sclerosant. Can happen if the balloon seal isn't perfect or there's reflux. Recognize it by sudden shortness of breath, chest pain, hypoxia during or right after injection. Prevention. Meticulous sclerosant technique. Ensure complete balloon occlusion. Watch fluoro closely for efflux. Management is supportive oxygen, maybe ventilation. Rare if done right. It is. Coil or plug migration is the main device-specific risk. Prevention, as we hammer home, is careful sizing, oversized plugs, size coils appropriately, and meticulous deployment. If migration does happen, say to the pulmonary artery, well, then you're looking at percutaneous retrieval.
Retrieval. Sounds tough.
It can be. Require snares or graspers, specialized skills, can be time-consuming. Best avoided through good upfront technique. Another issue, maybe more common if occlusion isn't perfect, is incomplete gastric varix obliteration. You might see persistent flow on follow-up scans. Management could be a repeat RTO session targeting the residual, or maybe adjunct endoscopic glue or banding if it's suitable.
So those are device issues. But what about complications common to all RTO techniques, the systemic effects?
Oh, right. These are often due to the hemodynamic shifts. Big one. Exacerbation of portal hypertension. Closing that big shunt redirects flow, increases portal pressure. This can worsen ascites, hydrothorax, or existing EVs.
How do we manage that?
Proactively. Consider beta blockers, manage fluids carefully post-op, adjust diuretics, monitor closely. Another major concern, renal insufficiency. Can be from sclerosant toxicity, especially IO causing hemolysis, or just contrast-induced nephropathy.
Prevention for kidneys.
Aggressive hydration before and after, minimize contrast volume where possible, monitor creatinine BUN closely. If function declines, supportive care, maybe nephrology consult.
What about post-embolization syndrome?
Yeah, post-embolization syndrome is common. Low-grade fever, belly pain, nausea. It's just inflammation from the varix thrombosis. Managed symptomatically, NSAIs, antiemetics, hydration, usually resolves in a few days.
Any others? Long-term?
Long-term shunt recanalization can happen. The shunt reopens months or years later. Patient might rebleed, needs repeat imaging, possibly repeat RTO. Less common but serious. Non-target embolization if sclerosant escapes, or very rarely renal vein thrombosis if the device or clot extends too far. Meticulous planning, careful technique, and thorough follow-up are your best defenses here.
Okay, weighing all this. How do BRTO, PARTO, and CARTO stack up in terms of procedure time and patient outcomes? What's the clinical bottom line for an IR choosing their method?
Well, the great news is technical success is high across the board. BRTO hits 99% obliteration, and PARTO-CARTO are right there with comparable success rates. That's consistently good.
But procedure time differs.
Significantly, PARTO and CARTO were generally much faster than BRTO. Why? That prolonged balloon dwell time in BRTO adds maybe 30, 45 plus minutes right there. With PARTO-CARTO, once the plug or coils are in, you're often done much quicker. Less fluoro time, less sedation time for the patient.
That's a definite advantage. What about long-term impact? Differences in portal pressure effects or recurrence?
Long-term, BRTO has a great track record for durable obliteration. But as we noted, it does carry that potential risk of worsening EVs or ascites due to the portal pressure shifts. It's a known trade-off. PARTO and CARTO seem to offer similar durability, but potentially with fewer exacerbations of portal hypertension.
Why fewer exacerbations?
Possibly because the mechanical occlusion is more definitive, maybe less systemic sclerosant effect, more contained within the target. Overall, though, any successful RTO offers huge benefits. Relief from bleeding, often no surgical scars, quick mobilization post-procedure. That's huge for these frail patients. Understanding these differences in mechanism, time, and specific risks helps you tailor the best approach for each individual.
What an incredibly detailed exploration. We've really gone from the finest anatomical points to the broad clinical management and technical choices.
We really have. We've covered the absolute necessity of deep anatomical knowledge, Sarin's guiding our focus, Kiyosu's afferent-efferent types dictating sclerosant strategy and predicting reflux, Hirota's functional grading flighting difficulty. It all feeds directly into planning and outcomes.
And the vital role of advanced imaging, CTA and MRA. They're not just pictures, they are truly our detailed procedural maps, indispensable for tracing shunts, measuring accurately, spotting those critical contraindications.
Couldn't agree more. And pairing that with meticulous clinical assessment, liver function, renal status, coagulation, fluid balance, it's all essential for patient selection and anticipating those systemic post-procedural effects. It truly demands that multidisciplinary teamwork.
And seeing the evolution BRTO to PARTO and CARTO really highlights how our field constantly refines techniques to boost safety, cut down procedure times, and improve long-term results, learning as we go.
Absolutely. In the end, it's that synergy, deep anatomical insight, precise imaging, comprehensive clinical care, and mastery of the techniques that leads to the best, safest outcomes for patients facing these life-threatening gastric varices. Knowing the patient, the anatomy, and the tools inside out.
Which brings us to a final thought for you to consider. As these RTO techniques get even more refined, imagine the future. How might things like real-time intraprocedural imaging advancements, or maybe even AI-driven hemodynamic modeling based on pre-op scans, further improve our ability to predict exactly how each individual patient will respond to shunt occlusion? Could we achieve even more personalized, virtually complication-free interventions down the line? Something to think about.